diabetes and insipidus. Insipidus, a word of Latin origin which means without taste. So basically, it was labeled insipidus because the urine was tasteless in this case. In times of Latin age, old age medicine, diabetes mellitus was diagnosed by tasting the urine of the patient. So if it was sweet, then it meant that the patient has diabetes mellitus. And then it was seen that some of the patients who were passing a lot of urine, their urine was tasteless. So that's why it was called diabetes insipidus. That's how bad things were for doctors in the past. So what is diabetes insipidus? It's inability of body to conserve water due to pathophysiology of production of antidiuretic hormone and its action. So antidiuretic hormone, we can understand from the name that it is the hormone which prevents the urine from excessive urination. So that's the hormone, and if there is some problem in the production of this hormone or its activity of this hormone, this can lead to diabetes insipidus. So what happens, this hormone, which is also called vasopressin, is produced in the hypothalamus and is stored in the posterior pituitary. It is released from the posterior pituitary and it goes into the kidneys, where there are receptors, aquareceptors, to which it bounds. These receptors, under the influence of this ADH or vasopressin, is responsible for reabsorption of urine, resulting in increased urine osmolality, that is, and decreased urine volume. And this decrease, when urine osmolality is increased, that means the water is reabsorbed. What will happen? The serum osmolality will decrease because there's a lot of fluid in the serum as well. And so now this is the thing which goes as a negative feedback. So we know that all the pituitary hormones, they are under the influence of negative feedback. So this pituitary hormone, this hormone is under the influence of serum osmolality. So as soon as the serum osmolality is decreased because of decreased urination under the influence of ADH, what happens is that hypothalamus decides that ADH is sufficient in the body, and hypothalamus decreases the levels of the ADH, and in this, which in turn really decreases the stored is ADH, and thus it is decreased from the pituitary gland. So that's how the normal physiology takes place. So when it is less, it will absorb less, the osmolality will be further increased urination, which will lead to increased serum osmolarity. So now if the lot of fluid starts getting out of here through the kidneys, if a lot of fluid is excreted, what will happen? There will be increase in serum osmolarity. This water will be reduced in the body and the sodium will be high in the body, and so when you calculate the osmolality, that will be increased when the ADH is reduced. So the signal goes to the brain, the body needs water. So the hypothalamus then secretes extra ADH, and which is stored extra, and this whole cycle keeps on going. So that's how the homeostasis of the sodium and water takes place in the body. So basically ADH is responsible for homeostasis of water in the body. So diabetes insipidus is hyposecretion of ADH or decreased action of the ADH. So some pathology with the ADH. So there are different etiologies, or you can say different types on the basis of the cause. It can be neurogenic diabetes insipidus when the pituitary is affected, or when hypothalamus is affected, then it is neurogenic. Okay? It can be nephrogenic when the kidneys are not functioning. Vasopressin is there, but the kidneys, they are not functioning. The receptors are not responding to the ADH. Then we have this nephrogenic. Gestational diabetes insipidus is another type. It occurs only in pregnancy. We'll talk about this. Adipsic diabetes insipidus, what patient is not taking water and there is a diabetes insipidus. primary polydipsia, dipsogenic diabetes, and psychogenic diabetes insipidus. Primary polydipsia, when patient is taking a lot of fluids, so that can be dipsogenic or that can be psychogenic diabetes insipidus. So what happens in neurogenic diabetes insipidus? There is ADH is deficient, which causes excessive diuresis, which causes increased serum osmolality, which causes hypernatremia and hypovolemic shock. But the pituitary is affected or hypothalamus is affected, so ADH remains low and the process keeps on going. So causes can be congenital, it can be idiopathic. Congenital is it can be an autosomal recessive or sex-linked disorder. Okay? So genetic disorder, patient is genetically some defect going on. It can be idiopathic. More than 50% of all cases are idiopathic. You are not able to find the cause of this neurogenic, why ADH is not being produced. Other causes are brain tumors, benign and malignant, metastatic brain tumors, meningioma, head trauma, surgery, brain thrombosis, hemorrhage, aneurysms. Then infections like meningitis, encephalitis, Guillain-Barré, so anything doing with the brain, okay? Granulomatous disease, tuberculosis, sarcoidosis, histiocytosis. In pregnancy, the neurogenic takes place because of the Sheehan syndrome. This is very important. What happens in the Sheehan syndrome is that patient at the time of the labor, the patient has a lot of bleeding. So what happens during pregnancy is that because of the increased production of the prolactin hormone, there is increase in size of the pituitary. Pituitary has to work hard, so it produces a lot of prolactin, it prepares that, so you have a large pituitary. The females, they get large pituitary in the pregnancy, and when the delivery takes place and if there is excessive loss of blood, so there is ischemia which happens in the pituitary gland, which results in damage to the pituitary gland, and then this in turn leads to complete loss of all the pituitary hormones. It can occur, this is known as Sheehan syndrome, and this can occur, all the hormones can go at the same time, and it can be acute and it can be chronic. Slowly and gradually hormones are going. The first one to go are the gonadotropins, the FSH, LH, and the last one to grow is the cortisol and thyroid, the ones which are very important for life. Causes of central diabetes insipidus, again the same. Okay, had trauma including pituitary surgery, neoplasms, primary craniopharyngiomas, pituitary adenomas, dysgerminoma, metastatic lung disease, lymphomas, leukemias, sarcoidosis, histiocytosis, chronic meningitis, viral encephalitis, toxoplasmosis, tetrodotoxin, snake venom. There's several causes of central diabetes insipidus. So what's nephrogenic? As I said, the nephrogenic is when the kidneys are not functioning, the aquaporin receptors which are under the effect of the ADH and are responsible for reabsorption of water, they are not functional usually, and that's why it takes place. There are several causes. This can be primary or congenital, X-linked recessive, autosomal dominant, or autosomal recessive. It can be required because of the tubulointerstitial nephropathies. So नेफ्रोपैथीज हो गई, पॉलीसिस्टिक किडनीज हो गई, हाइड्रोनेफ्रोसिस है, RTA, रीनल ट्यूबुलर एसिडोसिस, Fanconi syndromes, or secondary tubulointerstitial nephropathies because of the hypercalcemia, falciparum. So anything which is causing damage to the kidneys, there is something wrong with the kidneys themselves, or something, some infection like HIV infection, or the hypercalcemia, or from anemias. So anything, or the drugs like lithium carbonate, amphotericin, the nephrotoxic drugs. So anything wrong defecting the kidneys can lead to nephrogenic diabetes insipidus. So what is primary polydipsia? Primary polydipsia is when there is intake of large amount of the water. So when you take a lot of water, this leads to low plasma osmolality. सही है, जब पानी बहुत ले लेंगे तो osmolality कम हो जाएगी. So जब osmolality कम हो जाएगी, the production of ADH stops in the response to it. So ADH का function काम ही osmolality कम करना है. So already अगर osmolality कम हो जाएगी तो क्या होगा? ADH की प्रोडक्शन नहीं होगी, ठीक है, एज अ रिजल्ट ऑफ विच द कंसंट्रेटिंग एबिलिटी ऑफ द किडनी, सो अगर वो फ्लूइड, जब ADH नहीं आएगा तो किडनीज काम नहीं करेंगी, जब किडनीज काम नहीं करेंगी तो वो कंसंट्रेट नहीं करेंगी, एंड दिस विल रिजल्ट इन एक्सक्रीशन ऑफ लार्ज अमाउंट ऑफ dilute urine having low osmolarities. So there will be low urinary osmolality and there will be low plasma osmolality as well in this kind of ADH deficiency. ठीक है. Dyspogenic defect in the regulatory set point in hypothalamus. So here there is a thirst center in the hypothalamus, and it is set on a point. So that is the point when you start feeling thirsty. So there is defect in that regulatory set point in hypothalamus. Can be because of the injury, because of the infection, anything. So what happens, thirst mechanism becomes overactive and patient starts drinking large amount of water, and it is similar to something similar, and in turn something similar to primary polydipsia takes place. Okay, that's dyspogenic. Psychogenic, when patient, because of certain behavioral disorders or because of like people like obsessive compulsive disorders, they start drinking large amount of water, and when they start drinking large amount of water, they start producing large amount of dilute urine, and the thing which happens is the same, that is the production of ADH stops in response to the low plasma osmolality, and this low plasma is because of the excessive intake of the fluid. What is gestational? It occurs during pregnancy. Placenta produces a hormone known as vasopressinase. This vasopressinase, as the name indicates, it's a pressinase, so it is breaking down the vasopressin, which is the other name for antidiuretic hormone. So when there is excessive production of vasopressinase by the placenta, causes lack of functional vasopressin. So vasopressin is being produced, but it is not effective because it is being broken down more larger quantity. Adipsic, there is an absence of thirst although body is dehydrated. So patient is dehydrated, but still he is not able to take fluid. Okay, he doesn't feel thirsty, and this is because of any lesion of a thirst center in hypothalamus, which leads to loss of thirst. So patient is not drinking fluid, okay, or despite that he is dehydrated. So patient doesn't know because his thirst center is not able to understand this, that he needs to drink water. It is often associated with the CDI, is central diabetes insipidus, because a lesion of the hypothalamus also affects the supraoptic and paraventricular region. The supraoptic and paraventricular region are the regions from which ADH is secreted. So what will happen? So from this we have understood there will be polyuria, so excessive urine. When ADH is not there, there will be excessive urine, and to compensate for that, patient will be drinking a lot of water. When he will be drinking a lot of water, this will be leading to nocturia. So his excessively urine production takes place, and that is leading him to wake up at night to go to washroom to relieve himself, and this excessive water loss in turn also cause a lot of dehydration. So the classical symptom these patients give you, बर्फ वाला पानी पीने को दिल करता है, so they just want to have cold water because cold water gives them a feeling of satiety, of fullness, of the feeling of elimination of thirst, so they just want to have, so बहुत सारा पानी पीते हैं और बर्फ वाला पानी पीने को दिल करता है. That is what is they say. And बर्फ वाला पानी means, when patient says बर्फ वाला, it means that they are feeling dehydration. So what happens when the diabetes insipidus takes place? These are the main clinical features. Patient can present to you alert, conscious, oriented, talking to you, and he or she can come with loss of consciousness or decreased consciousness. So alert patient will tell you that he's always thirsty, he drinks a lot of water, and thus he will be replacing fluids. Okay? And this will be less extreme findings, which we will find hypernatremia and other electrolyte disturbance. It will be less extreme. Okay? but decrease, there will be history of polyuria, and when you will test a patient, there will be hypernatremia, severe hypernatremia, dehydration, decreased cerebral perfusion. They can have seizures, they can have coma and death. So if not treated properly and not treated in time, these patients can die. So how will you assess these patients? Biochemically, you will look at the urine output, and urine output will be more than 300 ml per hour. So 300 ml per hour means on almost 6 to 8 liters per day. So you have to quantify their urine. Low urine osmolality, when you will calculate osmolality, or when you will do the electrolytes and calculate the osmolality, you will find that they have low urine osmolality, and urine is insipidus or tasteless. Laboratory test, you also, so what will you do? First of all, when a patient will come to you and you are says to you कि मुझे बहुत ज़्यादा यूरिन आता है, मैं बहुत पेशाब करता हूँ, मैं जो हूँ वॉशरूम जाता रहता हूँ, मैं पानी भी बहुत पीता हूँ. So first differential which comes to your mind is diabetes mellitus. You will think of diabetes mellitus. Okay, diabetes में होता है ये polyuria होना, nocturia होना, सब कुछ होना. The another thing you have to think over here is diabetes insipidus. ठीक है? And then you will ask him to quantify this urine to check. ठीक है, आप ग्लूकोज वगैरह तो करवाओगे उसका, और शुगर टेस्ट और ये सारा कुछ कराओगे, और जब वो शुगर वगैरह उसकी नेगेटिव आएगी, you will exclude diabetes in these patients. But after excluding diabetes, what you will do is you will ask them to quantify the urine. ठीक है, so उसके लिए उनको कहा कि वो 24 घंटे का पेशाब जमा करें और देखें कि उन्होंने कितने लीटर पानी यूरिन आया है उनको, और साथ में ये भी देखना है कि वो कितने लीटर पानी पी रहे हैं, क्योंकि आपने प्राइमरी पॉलीडिप्सिया को भी डिफरेंशिएट करना है. सो इफ ही इज टेकन 10 liters of fluid and is excreting 10 liters of fluid, then this is primary polydipsia most probably. ठीक है, but if he is not taking that much of fluid, he's taking 5-6 liters and he's excreting 7-8 liters of the urine, then this means that there is a chance that the patient has diabetes insipidus. जो लैब टेस्ट आप कराएंगे, इसमें सीरम ऑस्मोलैलिटी कराएंगे, यूरिन ऑस्मोलैलिटी कराएंगे, सीरम सोडियम कराएंगे, और सीरम ADH लेवल्स करवा सकते हैं हम. ठीक है, सो आपने सोचा कि पेशेंट को DI है, ठीक है, आपका उसने आपको यूरिन बता दिया कि मोर देन 6 लीटर्स वो पास करता है, आपने लैब स्टडीज करनी है. You have to see for the sodium. So sodium levels, there will be hypernatremia 145, and osmolality will be greater than 320. और जब आप यूरिन osmolality करेंगे, it will be less than 300. It is a dilute urine. ठीक है, so आपने ये तीन चीज़ें देखनी है. सोडियम आपने देखना है 145 है, सीरम ऑस्मोलैलिटी आपने देखनी है कि 320 है, और यूरिन ऑस्मोलैलिटी आपने देखनी है which is less than 300. If you get all this along with increased urine output, then this means that this is diabetes insipidus. ठीक है, if you do not get this, then you have suspicion of diabetes insipidus, then you have to do the specialized test for this. We'll talk about that specialized test afterward in a minute. So you also have, as I said, there are the causes of polyuria. So blood sugars, diabetes mellitus is the very first differential you will have when the patient says कि भाई बहुत ज़्यादा यूरिन आ रहा है, बहुत रात को उठ के जा रहे हैं. सो ब्लड शुगर्स you will need to do, you need to see the kidneys, so it can be because of renal function, so you have to do the urea, creatinine, urine DR and everything. Uric acid is one of the, hyperuricemia is one of the causes of polyuria, so you will do that. And then hypokalemia, so if there is low potassium, then it can also cause polyuria, so you have to rule that out. Hypercalcemia, high calcium levels can do this, and hypomagnesemia also causes excessive urine loss. So you have to rule out all these abnormalities before saying the patient has DI. And after doing this, when you have ruled this all out, then you look at the sodium, serum osmolality and urine osmolality. Sodium is 145 if it is more than 145, serum osmolality if it is more than 320, and urine osmolality is less than 300. You diagnose patient with DI, diabetes insipidus. If any of these criteria is not being fulfilled, then you do a test known as water deprivation test. ठीक है. So as this says, you deprive the patient uh, from water. So what does this test do? This test not only helps you in confirming the diagnosis, but it also helps you in differentiating the two main types of diabetes, basically three main types of diabetes insipidus: the cranial, the nephrogenic, and the primary polydipsia. So what you will do in this is you will allow the patient to have free fluids, to eat and drink normally till 7:30 a.m. in the morning of the test. He comes at 8:30. At 8:30 you will start the test and you will do body weight, plasma, and urine osmolality. So you'll send plasma for the osmolality, you will send the urine osmolality, and you do a body weight. So you make a chart and you will mark them. Okay? Here then what will you do is you will tell them not to take fluid from now on. So they are not going any kind of fluid, any kind of water or fluid from that. And you will do the body weight, urine volume, urine osmolarity, plasma osmolarity, and thirst score on VAS or any sheet you have 2 hours, every 2 hours for up to 8 hours. So 8 घंटे तक उसको कुछ पानी पीने नहीं देना, कुछ करने नहीं देना. एंड आपने ये बॉडी वेट, यूरिन वॉल्यूम, यूरिन ऑस्मोलैरिटी, प्लाज्मा ऑस्मोलैरिटी और थर्स्ट स्कोर करना है. स्टॉप द टेस्ट इफ द पेशेंट लूजेस. सो या तो आप 8 घंटे के लिए करेंगे, ठीक है, या फिर इफ द पेशेंट लूजेस 3% ऑफ द बॉडी वेट. ठीक है, 3% ऑफ द बॉडी वेट उसने लूज कर लिया है. सो इसका मतलब है पानी सारा निकल गया. ठीक है, अब आप क्या करेंगे, यू विल और आप उसकी प्लाज्मा ऑस्मोलैरिटीज देंगे एंड यूरिन ऑस्मोलैरिटी देखेंगे. अगर उसकी प्लाज्मा ऑस्मोलैरिटी बढ़ के 300 हो गई है और यूरिन ऑस्मोलैरिटी 600 से भी कम है, सो आपने कहना है ये डायबिटीज इंसिपिडस है और फिर आपने इसको DDAVP दे देना है. ठीक है, DDAVP. सो आपने उसको पानी नहीं दिया और आपने देखा वो कितना कंसंट्रेट कर रहा है. सो वो कंसंट्रेट तो कर ही है, मगर उसकी यूरिन की ऑस्मोलैरिटी अभी भी कम है, 600 से कम है, 600 से कम है. इसका मतलब है कि ये जो है इसने कंसंट्रेट नहीं किया. बॉडी में तो फ्लूइड कम था जिस वजह से बॉडी कंसंट्रेट हो गई है, उसमें सोडियम बढ़ गया है और उसकी ऑस्मोलैरिटी बढ़ गई है. मगर इसका यूरिन जो है उसके लिए क्या होना चाहिए, नॉर्मली जब आप डिहाइड्रेट करते हैं तो आपको यूरिन नहीं आता है, मगर आपने जब ये ऑस्मोलैरिटी कराई तो ये लेस देन 600, कुछ बुक्स में 800 भी लिखा हुआ है. सो अगर 600 या 800 से कम नहीं हुई यानी 600 800, इसका मतलब है कि यूरिन कंसंट्रेट नहीं हुआ है. ठीक है, सो यू हैव टू सॉरी इससे कम है, 600 या 800 से कम है यूरिन, तो इसका मतलब है वो कंसंट्रेट नहीं हुआ, वो अभी भी डाइल्यूटेड है. ठीक है, सो अब इस वक्त तो यहाँ पे आपने इसको कह देना है कि ये डायबिटीज इंसिपिडस है. Now to find out whether it is cranial or whether it is nephrogenic, you give DDAVP. DDAVP is the synthetic form of antidiuretic hormone. So ये आप देते हैं 2 microgram IM. In Pakistan, this IM is not available, so we use nasal nasal ADH. ठीक है, वो that is available, we use that. सो फिर उसके बाद हम क्या करते हैं कि अगर प्लाज्मा इसको देने के बाद प्लाज्मा ऑस्मोलैरिटी, तो ये हमने कहा कि ये डायबिटीज इंसिपिडस है जब प्लाज्मा ऑस्मोलैरिटी मोर देन 300 थी और यूरिन की ऑस्मोलैरिटी लेस देन 600 थी, वो कंसंट्रेट नहीं किया उसने. इफ यूरिन ऑस्मोलैरिटी राइजेस बाय एटलीस्ट 50%, जब आपने DDAVP दिया उसको और एकदम से यूरिन कंसंट्रेट हो गया, मोर देन एटलीस्ट 50% कंसंट्रेट कर दिया, तो इसका मतलब है क्रेनियल डायबिटीज इंसिपिडस. मतलब ये कि उसकी बॉडी में ADH नहीं था और आपने जब बाहर से ADH दिया, it has caused the concentration of the urine. So there is deficiency, central cause है, there is central absence of ADH, and we will call it central diabetes insipidus. If DDAVP does not concentrate the urine, so you gave it and the urine still remains diluted, so this means that this is nephrogenic diabetes insipidus, because ADH was there, however, and you gave it to him, however it did not act on the receptors there. Primary polydipsia, that osmolality was low from the beginning and it remains low, as well as the urine osmolality remains. Okay. So after fluid deprivation, if it is less than 300, and after the urine osmolality was less than 300, okay, and after desmopressin, now these values, they vary from book to book, from center to center. Everyone has a different value. The easy is 300 to 800 is easy to remember. Neurogenic, you will call neurogenic if the after giving after fluid deprivation, it still remained diluted and it was less than 300. And then you gave desmopressin and it raised to more than 50% or more than 800. Okay? Nephrogenic, it remained diluted. Primary polydipsia, after fluid deprivation, it became more than 800, and after desmopressin, it remained more than 800. So it was the same. So what is the treatment goals? Restoration of circulating fluid volume. So क्या है basically? Dehydration है. So आपने dehydration को correct करना है. You have to correct. Then what is deficient? ADH is deficient, so you have to replace ADH. And then you look at the underlying cause and you treat the underlying condition. So how to do the circulatory volume? Restore the circulatory volume, clear fluid replacement. It is provided in the initial phase of the treatment to prevent circulatory collapse. Patients who are able to drink are given voluminous amount of fluid orally. For those who are unable to take sufficient fluids orally, hypotonic intravenous solutions are infused. Careful monitoring to restore the hemodynamic balance. So अब fluid देते हैं और carefully monitor करते हैं इन patients को. The replacement is also given very carefully. Medications to manage central, जो brain वाला है उसमें क्या करना है, अपने vasopressin दे सकते हैं, desmopressin दे सकते हैं, and lipressin दे सकते हैं. ठीक है? Usually which is given is desmopressin. That is the one which is given. This is the synthetic form of the ADH. They all are synthetic form of the ADH. So central जहाँ ADH नहीं है, you have to get ADH, replace ADH, and they are different. These are the three different synthetic forms available. In nephrogenic diabetes insipidus, where there is problem with the receptors and the kidneys are not responding, one is thiazide diuretics. So thiazide diuretics helps in helps in these patients. High dose of desmopressin. So you give high dose so that they can overcome the resistance of the receptors and then they act. And indomethacin, which is a prostaglandin synthase inhibitors. So they produce large amount of prostaglandin, which then helps in the absorption of the fluid. Primary polydipsia. In primary polydipsia, what you do is you treat the underlying pathology and you do fluid restriction. So if there is OCD, treat that. Other psychological disorders, you treat that. If you look for the adipsic patient, if it is adipsic, then tell him to take fluid. Behavioral therapy and medical therapy both will take place over here. So what's diabetes insipidus? You will have in a history, there can be head injury, or there can be pituitary tumor, or there can be craniotomy, history of pituitary surgery. Pituitary gland is small, with the help of the ADH stops the excretion of lot of urine. So if ADH is not there, this will take place. Okay? So what we have to do, signs and symptoms, up to 20 liter urine per day can take place. So that up to 20 liters can be there. Usually 6 to 8 liters is more than enough. Specific gravity is reduced, osmolality is reduced, there can be hypovolemia, thirst is increased, tachycardia, and there can be decreased blood pressure as fluid is not there, so decreased blood pressure. So you have to monitor fluids, you have to replace fluids, you have to look at the CNS status, neurostatus, vital signs, and you keep on looking at the membranes for hydration. Treatment is vasopressin and DDAPP. Okay, that is the synthetic form of the vasopressin. So small topic, seems easy, but the problem with this is that it makes, I don't know, I have always confused diabetes insipidus and SIADH. I just get confused. SIADH is a condition in which there is excessive production of the antidiuretic hormone. So when there is an excessive production of the antidiuretic hormone, opposite to diabetes insipidus will take place, and the causes are almost the same: head injury, pituitary tumors, craniotomy, and infections and lung causes. So in SIADH, the main cause is the lung. So any infection of the lung, the pneumonias, the tumors, the respiratory failure, ARDS, anything can cause, all of these then can cause excessive production of the ADH. So when there will be excessive production of the ADH, then there will be low urine. Okay, water will be retained, and when water fluid will be retained, then what will happen? Then the osmolarity, serum osmolarity there will be hypervolemia, so the osmolarity will fall. So there will be higher urine osmolarity and low serum osmolarity, and in there the fluid restriction is usually done. Okay, so these are the two: diabetes insipidus and SIADH. Okay ji, not simple, seems simple but not simple, always confusing, everyone is confused by them. So please go through this, and if you have any other questions, do tell me. Okay ji, Allah Hafiz.